We are like,
Good evening, everyone. I am Dr. Pathophysiology, your host, or you can call me moderator also for this 2-hour program. First of all, I would like to thank Dr. Santosh Honavar sir for giving us the opportunity to conduct a webinar on such an important topic. Now, if you see that the diagnosis and management of pediatric uveitis is very important and it requires very important in our clinics and it requires the utmost care. Now, I'll show you one study which we have retrospectively analyzed 255 children. And we realized that nearly 1/4 of these children had visual impairment, severe enough to categorized as blindness in at least one eye on presentation to our institute. And 21 children had bilateral blindness at the time of presentation. Now, so if you see the distribution of the subtypes of this uveitis in these children, you will realize and you will be surprised that 60% had the anterior uveitis. So you can understand why we need to be very careful about the uveitis in children. And the challenges we encounter in our day-to-day scenario are many. The number one, they won't allow you to examine. The child can be more difficult to examine than the adult, and complete examination is very difficult in these children. So we need a complete examination which can be done only under general anesthesia, which is not available in our day-to-day clinical practice, and many center it is not always possible. Further, this is further compounded by like poor view due to the synechiae formation, and there will be marked media opacity in the form of vitritis. So sometimes the diagnosis becomes very difficult. The number two challenge we find difficult to manage pediatric uveitis is that they are often the preverbal or asymptomatic and notoriously known to present late. The number three is, as I said, that the pediatric uveitis will have frequent complication. They are more prone for the amblyopia. They will develop strabismus, band keratopathy, and will come to your clinic. And sometimes you will start steroid, oral or topical, and they will have the side effects of the corticosteroid. And definitely they are the different subset of uveitis which require different surgical consideration. Now, as I said, the complication are the often presenting signs of uveitis in children. No, not only in India. If you see the studies, retrospective studies from the US also, you will see that 84.5% of these children presented to seek ophthalmic advice once they developed a complication. And not only this, its trouble does not come alone. So the complication can occur in both eyes, and sometimes if it is even in one eye, there can be more than one complication can occur. So that's why it's very important, and also important to understand that they have a unique presentation. These are the relatively uncommon presentations. They tend to have more Masquerade syndromes. They have unique entities like juvenile idiopathic arthritis, disproportionate amount of infectious uveitis, and different form of other kinds of disorder. So we have a fantastic lineup of the presenters and panelists from the same institute. These presenters will introduce the cases which will be then discussed by the panelist. For the first time, we are experimenting with the idea of a case presentation followed by three slide pearls from the respective panelists. So we have today's lineup includes cases of juvenile idiopathic arthritis, pars planitis, ocular tuberculosis, viral uveitis, masquerade mimicking uveitis, and ocular toxoplasmosis. I hope you like this session and enjoy this idea. Last but the most important is the pearls on management of pediatric uveitis by none other than Professor Amod Gupta sir. So if you are watching this program live, we request you to send your question to chat box either in AIOS YouTube channel, or if you are watching here, you can send it to our Zoom also. Now, let me introduce my co-host or the moderator of this evening, Dr. Bandana Pradeep. She has done her fellowship in uvea and ocular inflammation. She is also she's a cataract surgeon and uvea and medical retina expert, and she is presently working in SUT Academy of Medical Sciences, Thiruvananthapuram, Kerala. So over to Dr. Bandana Pradeep, who will be introducing all the panelists of today evening.
Thank you, sir. Let me just share my screen. Okay. First of all, thank you, sir. And let me begin by saying I'm deeply humbled and extremely honored to welcome you all this evening. We have an outstanding line of speakers and a fascinating catalog for discussion today. Our first speaker for today is from Narayana Nethralaya, Bengaluru, Dr. Anina Anna Thomas. She will be mentored by Dr. Padma Malini Mahendradas, who is the head of the Department of UVEITIS and NN Bengaluru. She will be speaking on juvenile idiopathic arthritis. From Aravind Eye Hospital, Coimbatore, we have our second speaker, Dr. Anu Joseph. She and her mentor and head of the department, Dr. Anuradha VK, will be discussing on a case of pars planitis. The next speaker we have is Dr. Vishnu Todi with a case of Masquerade syndrome. Dr. Mohit Dogra, assistant professor at the Advanced Eye Center, PGI Chandigarh, will head the panel. Dr. Rakshita Kien and her mentor, Dr. Arshi Ahmed, who is a senior consultant at Shankar Nethralaya, Chennai, is bringing to us a case of viral uveitis. Next, we have a case of ocular tuberculosis from LVPI Hyderabad, presented by Dr. Shruti Satpathy. Dr. Saumyava Basu, head of uveitis of the LVPI network, will be heading the case discussion. The last case for the day is brought from Sadhguru Netra Chigilsalaya Chitrakoot. We will be seeing a case of ocular toxoplasmosis by Dr. Aishwari Revankar and her teacher, mentor, and head of the department at SNC Chitrakoot, Dr. Alok Singh. Nevertheless, it's an absolute honor to have Padma Shri Dr. Amod Gupta with us this evening. A towering figure in ophthalmology, he is recognized as one of the unsung heroes in the field by the AO. We are privileged to have him with us for the final talk of the day, 10 Pearls of Managing Uveitis in Children. So that's the Revit panel we have today. To start off with our first case, I invite Dr. Anina Anna Thomas and Dr. Padma Malini Mahendradas to head the session.
Thank you, ma'am.
Okay.
I hope I'm audible and my slides are visible.
Yes.
Good evening, all. At the outset, I'd like to thank AIOS and my mentor, Dr. Padma Malini ma'am, for this opportunity. So coming to the first case. So this is a 3-year-old girl child who presented to us with a history of redness and pain for 4 months. There's no significant systemic history or complaints. Now coming to her examination, the vision in the right eye was 6/24, intraocular pressure was 30 millimeters of mercury. The left eye vision was 6/18, intraocular pressure was 17 millimeters of mercury. Coming to her anterior segment examination, in the right eye, she had band-shaped keratopathy, cells and flare of 1+, posterior synechia, lens changes. Posterior segment examination showed a CDR of 0.7. Rest of the fundus examination was within normal limits. Now coming to the left eye, she had early BSK, changes in the left eye, traces of cells, flare plus, posterior synechia, lens changes, a CDR of 0.5. Rest of the fundus was within normal limits. Now coming to her investigations, her ESR was raised and an ANA by immunofluorescent assay was 1+ positive. The rest of the investigations were within normal limits. So this was a 3-year-old girl child with bilateral chronic non-granulomatous uveitis with complicated cataract with band-shaped keratopathy with secondary glaucoma in the right eye. So she was started on topical steroids, cycloplegics, and anti-glaucoma medications. We also referred her to the rheumatologist for systemic evaluation, where she was diagnosed as juvenile idiopathic arthritis. The term at that point in time was juvenile rheumatoid arthritis. The child was then started on a short course of oral steroids with methotrexate, 7.5 milligram per week. Now, coming to the management of the complications one by one, with regards to glaucoma, we did a thorough workup. The pachymetry showed a thicker cornea. She was uncooperative for gonioscopic examination. Visual fields showed a generalized reduction in the right eye, most likely due to the band-shaped keratopathy. The left eye did not show any glaucomatous field effects. The CDR in the right eye was 0.7, left eye was 0.5, which remained stable throughout the course of treatment. The IOP was well controlled with medical management. Now, coming to the next complication, the child, once the intraocular inflammation settled down, the child also underwent a right eye EDTA chelation under general anesthesia. This picture was taken post-procedure and she achieved a visual acuity of 6/9 parts. Now coming to the management timeline spanning over 18 years. She came to us first in 2006. She was 3 years old. Her visual acuity in the right eye was 6/24, left eye was 6/18. She showed features suggestive of chronic bilateral anterior uveitis. She was sent for systemic evaluation where she was diagnosed as a case of juvenile idiopathic arthritis. Methotrexate was initiated. In view of persisting intraocular inflammation, MMF was added, but unfortunately, later down the line, she developed joint swelling which prompted us to shift to biologics. So she was started on infliximab 100 mg. She received over 24 infusions from the period of 2010 to 2013. She also underwent 2 rounds of EDTA chelation. At this point, I'd like to highlight that adalimumab was not available in India at that point in time, which is why we went ahead with infliximab. Later on, the child had a bout of typhoid fever when the liver enzymes shot up. Due to this reason, the methotrexate had to be stopped and then restarted. So the patient came to us last year. She is now 21 years old and doing well. Vision in the right eye 6/12 and the left eye is 6/9. Her intraocular pressure is well controlled on AGM and she is on methotrexate 20 mg per week. Now coming to the second case, this is a 7-year-old boy who was referred by the rheumatologist as a diagnosed case of ANA positive oligoarticular juvenile idiopathic arthritis, who later developed GIA uveitis for our opinion. On examination, the right eye vision was 6/6 in the right eye, intraocular pressure was normal, anterior chamber showed traces of cells, posterior segment was within normal limits. Left eye examination showed vision of 6/6, intraocular pressure was 10 millimeters of mercury, anterior and posterior segment examination was within normal limits. Now we confirmed the findings with the help of an anterior segment OCT. So this was a case of right eye anterior uveitis already on immunomodulatory treatment. He was taking methotrexate 15 mg along with injection adalimumab 20 mg. The child was started on low-dose topical steroids and is continuing the immunomodulatory therapy. And we are reviewing him every 3 months. Now coming to the conclusion, GIA is the most commonest rheumatic disease in children. GIA-associated uveitis is asymptomatic in most cases. On evaluation, will have features of chronic anterior uveitis. In 3 to 7% of the cases, the uveitis can precede the GIA diagnosis. Early introduction of systemic immunosuppressive therapies must be aimed for. There's convincing evidence for the use of adalimumab in GIA-associated uveitis in patients who fail to respond adequately to methotrexate, as proven by the Sycamore trial. Thank you.
Thank you, Dr. Anina, for presenting these 2 challenging cases. Here, we have presented 2 cases. Most of the times, this child, like Dr. Partho highlighted the challenges, they present with complications at the time of diagnosis. So here, we control the inflammation with immunosuppressive therapy. When the biologics was available, we were able to control the inflammations and maintain with the methotrexate. The second case was diagnosed by the rheumatologist and referred to us for ophthalmic evaluation. The subtle inflammations, we could pick it up and started the child on treatment. Coming to the discussion, I would like to put three pearls. One, how do we diagnose JEA uveitis when the clinical pearls? The second, what are the treatment guidelines available? And third, if the child diagnosed with JEA, how are we going to screen? So JEA uveitis, most often they present with white uveitis. Sometimes they have mild congestion as seen in a first case. They are asymptomatic, bilateral involvement, most of the times asymmetrical presentation. The clinical picture is chronic anterior uveitis of non-granulomatous type. When they develop complications, they can present with band-shaped keratopathy, complicated cataract, secondary glaucoma, and so on. Coming to the treatment algorithm, whenever we diagnose, we start the child on topical steroids and cycloplegic agents. If the child has poor visual acuity, hypotony, macular edema, or vitreous opacities, we also had additional oral steroids. Then start the child on systemic immunosuppressive therapy. If the child is showing response to treatment, we'll continue the therapy. Within 3 months, if the child does not show any improvement, we'll add biologics. The preferable one is injection adalimumab because of the subcutaneous route of administration, and you assess. If they still is not responding, then we can add injection tablet methotrexate or change into injection methotrexate. We wait for the response. Initially, the child may respond and later they can be refractory due to the development of autoantibody formations. In that situations, we'll assess the clinical situations. It can be switched over to other biologics such as infliximab or tocilizumab. Coming to the screening guidelines, whenever we see a child, we have, in addition to the ocular uveitic evaluations, systemic evaluation has to be done. Depending upon the systemic type of JAA, the follow-up schedule varies. If the child has systemic JAA, polyarthritis with RF factor positive, enthesitis-related arthritis, usually they will have milder form of the disease and we'll follow them screening 6 to 12 months. If they have oligoarthritis, polyarthritis with RF factor negative, psoriatic or undifferentiated, again can be divided into ANA positive or ANA negative. ANA positive, less than 7 years with more than 4 years of duration is high-risk case. Screening has to be done every 3 months. ANA negative with the same criteria, the screening can be done in 6 to 12 months because of the moderate risk. JEA patients with inactive uveitis, if they're taking, we have to taper the discontinuation of the therapy. During tapering, we'll stop the topical steroid first, followed by systemic therapy. Ophthalmological examinations, following the topical steroid therapy reductions, we see the child within 1 month. Systemic steroid therapy, we see them after 2 months. If the patient on stable therapy, no change in the therapy, ophthalmological examination can be done in every 3 months in inactive cases. Active uveitis, the follow-up is decided by the treating ophthalmologist depending upon the inflammation. Once we start the therapy, the child starts responding. The question is, when do we start tapering? If the child is taking 1 to 2 drops of per day or needed to maintain the control of inflammation 3 months or longer, then we have to add the systemic immunosuppressive therapy. After adding the systemic immunosuppressive therapy, again with 1 to 2 drops, we are not able to taper, then we escalate the systemic immunosuppressive dose. In that, if the inflammation is controlled, we stop the topical steroid first, followed by systemic immunosuppressive therapy. There should be at least 2 years of quiescence before beginning to taper the systemic medications. But in biologics, we don't follow this rule depending upon the affordability, and we try to get the remissions and maintain with the systemic immunosuppressive therapy. To conclude, JEA is the commonest cause of rheumatic disease in children. They present with chronic anterior uveitis. Early diagnosis and aggressive therapy is important to control the inflammations and prevent the complications. Adalimumab in JEA-associated uveitis provide convincing evidence for the role of the biologic patients who fail to respond to conventional therapy. So thank you for your attention.
Thanks, ma'am. So how often you refer these children to the rheumatologist? Like any patient or any children coming with anterior uveitis, so do you refer all of them to rheumatologists to rule out GIA?
No, we just try to find out what kind of inflammation the child has. Get the systemic workup done. If you are suspecting JEA-related uveitis, Then we refer the patient to the dermatologist for further management, or you have done the investigations if it is idiopathic category where the child needs systemic immunosuppressions. In that situations, I'll refer the patient to the dermatologist, not all patients.
Thank you. So there is a question from Dr. Tanya Jain, who is asking any experience with tofacitinib. Have you used tofacitinib, ma'am, in any patients of JIA?
We did use few patients who cannot afford for the biologics. It works in milder form of JEA-related uveitis, not in severe form.
Severe. So thank you, ma'am. So the takeaway part from this madam's and Anina's presentation is that if you are suspecting a case of chronic anterior uveitis, which can be without congestion or white uveitis, don't try to treat them only with topical steroid. You have to rule out JIA in such patients, and it's very important to treat them with some systemic immunosuppressive if not responding to biologic in these cases. So any patient with chronic uveitis, as madam suggested that these patients can have particular clinical phenotype, you need to refer these patients to rheumatologists and exclude the causes of JIE. So now from Narayan Netralaya, Bengaluru, we'll move to Arvind Eye Hospital. This time, Arvind Eye Hospital, Coimbatore is joining us. So may I invite Dr. Anu Joseph and her mentor, Dr. Anuradha, to present a child with pars planitis and give us important parts how to decode a case, such a case of pars planitis. Over to you, Dr. Anu.
Good evening, sir. Thanks to AIS and my mentor, Dr. Anuradha Madam, for this opportunity. I'll be sharing my screen. Are my slides visible?
Yes, doctor. Also, can you please start your camera?
Okay. Our child is a 10-year-old male child presenting with complaints of defective vision for a duration of 3 months. He did not give any history of redness, pain, or photophobia. He did not have any history of childhood TB contact in the family, joint pains, oral ulcers, skin lesions, or did not have any pets at home. So he consulted locally and he was evaluated in detail and started on a course of oral steroids. His QTB gold was negative, serum ACE levels was within normal limits, and he was started on oral steroids, omnicotyl dose 20 milligram once daily in tapering. He was symptomatically better. He presented to us once the symptoms recurred, once the dose was tapered to 2.5 milligram OD dose. So on presentation to us, his best corrected visual acuity in the right eye was 6.6 parts and the left eye was 6.6. Anterior segment, both eye had 0.5 cells, and fundus showed grade 1 to 2 vitritis. And this is the right eye fundus picture showing the snowballs and the peripheral snow banking. So we ran the baseline investigations again, which included complete blood count, ESR, random blood sugar, MAN2, chest X-ray, and TPHA, and restarted him on oral steroids of 20 milligram OD dose. And it was tapered slowly. We also sent a referral letter to the rheumatologist asking to add immunosuppression in view of the recurrence of the intermediate uveitis. The rheumatologist started on 7.5 milligram weekly dose of methotrexate, which was hiked to 15 milligram weekly. This was the OCT at the time of presentation. Both eyes showed early ERM. And he improved, his symptoms were better, and he improved, and he was followed up for the next 1 to 2 months, and we slow tapered the oral steroids. Later, the child was lost to follow-up for a period of 9 months, in which 6 months he had stopped the medications. Later on, when he presented, his visual acuity in the right eye was 6.12 and left eye was 6.24. Both eyes showed anterior segment with 0.5 cells and had mild lens changes. Posterior segment again had grade 2 vitritis. This time, the left eye had cystoid macular edema. So we again ran the baseline test as mentioned before and restarted him on oral steroids, 20 milligram OD, and sent a referral letter to the rheumatologist. The rheumatologist this time had started on methotrexate 10 milligram weekly and was hiked to 15 milligram weekly in another 2 weeks. The child improved, but the resolution was too slow and the vitritis was persistent. So in view of that, we had to refer him for starting biologicals to the rheumatologist. And the child is yet to be followed up. And his vision in the right eye had improved to 6.6 and the left eye it was 6.18. Thank you.
Thank you to AIOS and Dr. Pathu for asking me to be part of this program. So, just going to start sharing. Are these slides visible?
Yes, ma'am.
Yeah. So, Pathu wanted to keep it brief and sweet, just share a few pearls with regard to management. So in 2021, there was a revision of diagnostic criteria of intermediate uveitis by the Sun Group, and they actually made it more extensive, with intermediate uveitis being classified as those associated with systemic diseases like syphilis and sarcoidosis and multiple sclerosis. And the pattern of intermediate uveitis, which is just limited to the eye, no systemic component to it, and it's non-infectious. So the one which is limited to the eye, the intermediate, is classified into pars planitis type and the non-pars planitis type. The difference being the presence of snowballs and snow banking in pars planitis. You also need to make a note that to identify uveitis as being pars planitis, you also need to have an absence of significant anterior chamber reaction. You have to have an absence of focal lesions in the fundus like retinitis or choroiditis, as well as vascular occlusion or occlusive vasculitis in the posterior pole or mid-periphery. So occlusive vasculitis in the far periphery is kind of okay, you still accept it as pars planitis. At the same time, because intermediate uveitis or pars planitis does not offer a lot of clues to etiology by examination, so you need to rule out both infectious and non-infectious diseases by doing the appropriate lab work or by clinical examination. So it's very important that you do a thorough indirect ophthalmoscopy before labeling somebody as having pars planitis, because through a hazy media, it's very easy to miss a focal lesion. It's also important to differentiate a peripheral granuloma like a toxoplasma granuloma or a vasoproliferative tumor from snow banking. Now, coming to how these children present, it's got a very slow onset. It's gradually progressive, and the patients present with gradual decrease in vision, which might be either due to the vitritis or just as often it might be due to complications like cataract and cystoid macular edema. And what we need to understand is that the complications in a disease like pars planitis is partly due to the disease and partly due to the management. For example, if you think about ocular hypertension, glaucoma and cataract, inappropriate use of steroids is, contributes just as much as poorly controlled inflammation. So as a matter of routine, you should not be starting topical steroids in pars planitis because, like we mentioned, the anterior chamber is relatively quiet. If there is a cystoid macular edema, you might want to add topical steroids. It's very difficult to identify cystoid macular edema through a haze, so I find OCT very useful in pars planitis in identifying cystoid macular edema as well as the structural changes associated with it, like epiretinal membrane or vitreomacular traction. And the last point I want to make about managing pars planitis is, or for that matter, to generalize any immune-mediated disease. If I want to kind of oversimplify it, I think the goal is to prevent an acute event from becoming recurrent and a recurrent event from becoming chronic, particularly in a child, because you actually, subjecting them to a lifelong of, visual impairment. So although systemic steroids and deposteroids are used as first line of treatment in pars planitis, you should have a very low threshold for moving on to conventional antimetabolites. And this is because not only do the conventional antimetabolites provide better control of inflammation, it also reduces the risk of complications which can result in permanent visual disability like macular edema or glaucoma. So the most commonly used antimetabolite is methotrexate, but mycophenolate, azathioprine, cyclosporine have also been used. If the conventional immunosuppressive doesn't work, injection adalimumab has excellent results in pars planitis. It's also very useful in treating macular edema. Thank you.
Thanks, ma'am. So it's I'll just ask want to highlight one point also, that if there is a severe vitreitis and one cannot make out that what is happening inside, do you recommend giving intravitreal injection?
Not at all. If I am totally, not for giving depot injections when I don't know what is happening behind. I don't do it. I think, when you don't have a view of fundus and you or in a situation where you don't know whether you're dealing with an infectious or a non-infectious disease, the safest way to go is systemic steroids.
Thank you, ma'am. Thank you. I think you have highlighted very important point that topical steroid is of no use. Alone, you should not use topical steroid. And the second thing is that don't inject any implant or any injection when you are not sure what is happening inside. So these are the very important point, and these are the patient will require early immunosuppressives if it is non-infectious. I think very nicely highlighted. Thank you. Thank you, ma'am. So Dr. Bandana, over to you.
Thank you, Dr. Anu, and thank you, Dr. Anuradha, ma'am. That was an engaging discussion. Next, let's welcome Dr. Vishnu Todi for his next case. For the next case presentation, he'll be presenting a case on masquerades mimicking uveitis. And I also welcome Dr. Mohit Dogra to steer the discussion.
Thank you. I would like to thank the UVEITIS team and my mentor, Dr. Mohit sir, for this wonderful opportunity. I'm sharing my slides. Is my slides visible?
Yes, just make it.
Yes.
I'm moving forward with my topic, child with masquerade mimicking uveitis. A 5-year-old girl with a history of trauma to her right eye presented to advanced eye center with complaints of diminution of vision in her right eye. The trauma in her right eye was with a wooden stick. She had visited multiple centers before coming to advanced eye center. She was diagnosed as a case of traumatic uveitis and was treated with topical steroids and cycloplasics. Following this treatment, she was having partial resolution of her symptoms, after which the symptoms again appeared. Then she visited to another center where she was diagnosed as a case of traumatic cataract and she was advised for cataract surgery. The patient was not, patient relatives were not satisfied, so they visited another hospital where she was diagnosed as a case of traumatic endophthalmitis and was advised for pars plana vitrectomy with intravitreal antibiotics and was referred to advanced eye center. On presentation to advanced eye center, the patient was having a visual acuity of 2/60 in her right eye. On examination, there was no conjunctival congestion in right eye. Cornea was relatively clear. There were presence of irregular whitish, fluffy, hypopion-like material in the anterior chamber, with ascent along the horizontal meridian nasally, which could be better appreciated in the magnified picture. The lens was clear and there was no posterior synecdoche. On further evaluation, there was presence of retrolental opacities in the anterior vitreous. On fundus examination, the media was grade 2. We could see a yellowish white lesion on the superotemporal quadrant with irregular margins, with multiple yellowish white opacities in the vitreous along the temporal quadrant. On further examination, we did a USG B/A scan and transverse mode, where we could appreciate a hyperechoic lesion on the superotemporal quadrant. Along with it, we can see some hyperechoic structures within the mass lesion depicted by the red arrow, with corresponding hyperreflectivity on the A scan, with backshadowing suggestive of calcification. On evaluation of the other eye, we could appreciate the media was grade 1 with vertically oval disc on the temporal periphery along the inferior arc just anterior to equator. We could see a mass lesion which was roughly around 2 to 3 disc diameter in size. Now, if considering all these things, like in the anterior chamber, the first peak, we could see a pseudo hypopion-like picture with mass-like lesion along the superior temporal quadrant with multiple opacities in the vitreous in the temporal quadrant, with calcification documented on the ultrasound. We made a diagnosis of retinoblastoma, which was masquerading as a hypopion uveitis.
Thank you. Thank you, Vishnu. Vishnu, can you go back to your second slide, please?
Yes, sure.
Yes, thank you. Thank you. So again, I'm not going to be giving, masquerades, especially malignant masquerades in kids, in children, and the most notorious one is retinoblastoma. Fortunately, they don't come to us that often. But when they do, the issue is that because we do not see them that often, they are often misdiagnosed and, sad to say, not treated well, as can be seen in that short summary on the top of this slide. This is actually how the patient came. The patient was actually scheduled to undergo cataract extraction at one of the centers under general anesthesia, had already been seen by the anesthesia team, and was actually set to undergo surgery the day after when this patient came to me in the clinic. And honestly, this is a clinical diagnosis. You can go to town about trying to do all kinds of fancy imaging, none of which are required. And why I want to say that is, if you were to look at this eye, and there is history of trauma. While that may be important in certain circumstances, for the most part, for a lot of posterior segment disease, be it uveitis or retina, erroneous history of trauma is generally attributed by the patient, which is generally not forthcoming. And even if it is, it's actually not connected. And one does not need to affect your clinical judgment by keeping that history in mind. Only because there was a history of trauma to a wooden stick, someone saw those white masses and thought it's ruptured anterior capsule with cortical matter in the AC. Someone else thought that it's not that because there was something going on in the vitreous. That guy was a bit smarter than the first guy, maybe. And, he thought that, no, this is endophthalmitis because there is trauma. Now, what one needs to know and see very clearly just by these two slides and not looking at anything else is there is no congestion in this eye. I mean, we're able to get excellent photos of this kid. There is absolutely no congestion, no lid edema. The eye is a white eye. You cannot make, even in the higher magnification, any kind of a cellular reaction cannot be made out in the right eye. There is no fibrin. And if you were to follow the magged up image, you can see all the four Purkinje images, including P3, P4, which is the front and back of the lens. Now, if one's suspecting that there is lens trauma, you cannot have intact lens capsules and those things marching into the anterior chamber, right? And Vishnu, if you were to go to just one slide post discussion, please. Anytime in a kid there is any dilemma, if there is anything that you feel, if it's an infectious endophthalmitis, or if there's a confusion with any kind of endogenous or infectious endophthalmitis with the kid, please try and follow this. It's easy, and mind you, I'll repeat one more time, it's clinical. Please see the patient. Infectious endophthalmitis, we know there'll be pain, there'll be extraocular signs, or there'll be lid swelling, it'll be a red eye, it won't be a white eye. The kid will be photophobic. You will not be able to get imaging photos done as well as you can, as well as you could for this kid. The hypopion in infectious endophthalmitis, trauma, or even if it's endogenous, there will be a massive breakdown of the blood ocular barrier, blood aqueous barrier. There will be outpouring of cells, proteins, fibrin, and the hypopion can be all kinds of shapes depending on what kind of organism it is, convex, concave, whatever. But there will be presence of fibrin along with that. For the most part, it will be immobile, and it will generally not be multifocal studded all over, as you can see here. There is no fibrin here. These cells are large, irregular. These cells have contact inhibition, the malignant cells, and that's why they are malignant, and they will spread all over. You make the child tilt, and this will happen. There will be no synechiae and retinoblastoma. Vitreous examination looks similar in both. However, you will not be able to see, if the media clarity allows, any kind of a mass lesion in infectious endophthalmitis. You might be able to, in cases of intraocular foreign bodies, but your trusted ultrasound will come to your rescue then, and it'll actually show you the differences. And mind you, this patient actually did not have the diffuse infiltrating variety of retinoblastoma, which most commonly presents and masquerades as hypopion uveitis, and that has no calcification. So please don't think that if you do not get calcification on ultrasound, it cannot be retinoblastoma. Anytime, I'm just going to finish with two lines. Professor Amod Gupta, my mentor, is here, and I learned this from Sir, I think, during many years ago, during my first year of post-graduation. Anytime in a kid there is unexplained phthisis, unexplained neovascular glaucoma, unexplained ciliary staphyloma, unexplained, aseptal cellulitis. Hello?
Yeah, Mohit.
Am I? Yeah, sorry.
Yeah,
This,
we can hear.
or unexplained, aseptal cellulitis, or unexplained hyphema, any one of these, please try and, try to actively look for a tumor. The most common of that is retinoblastoma. Please don't go around poking needles, doing surgeries, doing invasive maneuvers if you don't understand those things, because you'll make ocular disease, which has bad prognosis, into extraocular, orbital, maybe systemic, with extremely poor prognosis, and even at the increasing risk for mortality also. Thank you.
Thanks, thanks, Mohit, Dr. Mohit and Dr. Vishnu. I think that's a wonderful case you people have presented and highlighted very important points. So this can be actually the wolf in sheep's clothing. So I think it's you have highlighted that one should not do invasive surgery in these patients. So I think it's very important not to do AC tap in such cases also, because sometimes we see that hypopion and thinking it like endophthalmitis or some other infectious entity, people may tend to do AC tap. So I think it's very important to do that. So I think we have already 3 cases, but we have finished. So I'd just like to bring Professor Amod Gupta, sir. Sir, are you there?
I'm there.
Yeah. Sir, I just want to know from you that why there is so much confusion in children. Like if we miss, if the children is presenting with without congestion, we can actually misdiagnose the GIA, we can misdiagnose the Masquerade, and sometimes we have seen that the children present with some kind of redness, and some uveitic entity will be mistreated or misdiagnosed as allergic conjunctivitis. And most of the time we see the ophthalmologist treating them right and left with only with topical steroid, until and unless they're coming with some kind of complications like cataract, secondary glaucoma and all. So can you just highlight?
I think Partho, Mohit very well, said it, that the clinical examination is something which lacking in Indian ophthalmologists, and last 50 years, I have seen this happening time and again, that people are interested in writing a prescription, do a definitive procedure, do an invasive procedure, remove the cataract, do whatever they can do. They want to do it without doing an adequate and complete ocular examination. I think he has very nicely discussed this particular example. It's an eye opener for all ophthalmologists in India. They may have all the fancy gadgets and surgical microscopes and lysectomy and, cataract surgery setups, but most of them, majority, unfortunately, they lack clinical sense. And probably that is a reflection of their clinical training, that they have not had a training which should come very handy when you come across a child like this, where number two is, apart from that, the children are they are neglected a lot among all the age groups and genders. Women we always thought were, kind of neglected, but the children are most neglected. They don't have symptoms, they don't complain, they don't know what's going on, and they'll be accidentally discovered to have a poor vision either by the teachers in the classroom or when he's, bumping into objects in the house, the mothers would. And they will be, no, I don't have time. The parents, the fathers typically have no time for the children, and that's how they get neglected. Otherwise, any smart parent would pick up the child. There is something wrong with the child. The children don't make complaints, and majority of the problems in children, are asymptomatic or till the child loses vision many times irreparably. So I think these are the two issues. So this combination is a very deadly combination. And I think this particular case is the highlight of your session, I would say. How people get carried away trying to do surgical procedures and not apply their mind at all.
Thank you. So I think, sir, another in a busy clinic, when a child comes, so because the child will be crying and all, so the clinician also will be in a hurry to get rid of the patient and just.
Yeah, you have to gain, Partho, you have to gain confidence of the small children. It doesn't have to be a crowded room. You need to see with the help of the parent, the mother mostly. And fortunately for us, more than 90%, and I presented this, my own data about 24 or 5 years ago in one of the UVEITIS meetings, where I have shown that more than 90% of the children are above the age of 5 years, and we could do every examination except perhaps the UBM. I could get it done in about 2/3 of the cases. It was not required for all, but we could do it under general anesthesia if it was not possible without anesthesia. We could record the pressures, we could do the fundus biomicroscopy, we could do a slit lamp biomicroscopy. All examinations are possible. You need to make them comfortable, provide them a stool or a small, stuff on which they can be involved in the clinical care. You don't have to show rush or hesitation or, I don't think, I have not come across a crying child coming into the clinic. You have to gain the trust. Maybe the first visit, maybe you can call them again, second time, third time, and maybe you can keep a small, toy or toffee or gain the trust, a sweet or a lollipop or something. They'll happily come to you.
Yeah, I have seen that Dr. Jyotirmoy Viswas sir always will keep chocolate, and whenever a child will come, you'll first give the child a chocolate and then we'll start. Another thing I just want to ask your opinion, because I have seen in my clinical practice sometimes the optos plays a huge role, because these children, sometimes they don't allow you to examine their fundus. So sometimes the optos, if you have the facility of optos, it can be a very excellent tool to see the fundus.
Obviously, optos or the ultra wide fundus photography is the tool for the modern day practice. You can't have those old 35 or 50 degrees fundus cameras to examine these patients, because they are a great substitute for binocular indirect ophthalmoscopy, even for detecting retinal breaks and retinal detachments, peripheral retinoschisis and other things, in retina practice. So if you can afford it, I doubt if the prices have come down, but if one can afford, then nothing like it. Yeah.
Thank you, sir. So just one more question, because a lot of general ophthalmologists are watching this program live. How powerful is the topical steroid? Because I have seen the people treating retinitis, treating choroiditis, everything with topical steroid, and referring the patient when the patient coming already the damage has been done. So I just want to hear it.
Topical steroids don't penetrate beyond the anterior chamber, except for difluprednate, which does work in patients with CME, but the almost 25 to 30% of these eyes will develop glaucoma, raised intraocular pressure. So if you can monitor the pressure, maybe flupred 4 times a day would be a good substitute for topical dexamethasone. But remember, most of the times it will not penetrate beyond the anterior chamber. So if you have vitritis, or if you have CME, so DEXA drops or betamethasone drops, or or blood drops, they will not penetrate the eye. So they are only meant for anterior chamber, anterior uveitis at best.
Thank you, sir. So topical steroid is not the panacea for all kind of uveitis. Dr. Vishnu, can you unshare your screen? Yeah. So next we have the team from Shankar Netralaya. We have Dr. Rakshita Kene and her mentor, Dr. Arshi Ahmed, will be presenting the case. Over to you, Dr. Rakshita.
Good evening. Thank you, Team AIOS. Thank you, Partho sir and Arshi ma'am, for this opportunity. My screen is visible, sir?
Yeah, it's visible.
So I will be presenting a case of child with viral retinitis. A 5-year-old girl presented to us with chief complaints of redness in her left eye for 2 weeks. She denied any history of fever, rashes, or any systemic illness. However, there was history of 1 episode of seizures at 21 days of age. On examination, the best corrected visual acuity in her right eye was 6 by 7.5 and left eye was 6 by 36. The right eye anterior segment examination was unremarkable, and left eye examination showed endothelial dusting of pigments over the cornea. There was AC reaction of cells 4+, flare 2+, and there was trace fibrin. There was posterior synecdoche, lens was clear, and anterior vitreous phase showed plenty of cells. On posterior segment examination, right eye examination was within normal limits, while the left eye examination showed dense media haze, disc was hazily seen, and there were multiple yellowish confluent retinitis lesion along the inferior and inferotemporal arcade, suggestive of acute retinal necrosis. Further, she underwent ultrasound B scan of left eye. We showed moderate to high reflective membrane echo originating from optic nerve head to inferior and inferotemporal quadrant periphery, which had no shifting fluid. Thus, we established a provisional diagnosis of acute retinal necrosis, and to rule out the CNS involvement, she underwent MRI brain, which showed multiple tiny chronic hemorrhages in bilateral frontoparietal and subcortical region. However, the CSF analysis was negative for herpes simplex virus. So on the basis of clinical diagnosis, she was started on treatment with intravenous acyclovir 200 milligram thrice a day under the care of pediatrician. So 3 days after starting intravenous acyclovir, she underwent aqueous aspirate PCR for viruses, which was positive for herpes simplex virus with a huge viral load. We then treated her also with intravitreal ganciclovir. 1 week later, her visual acuity deteriorated to counting finger at 2 meters in left eye. She was then started on oral steroids, 0.7 milligram per kg per day, and IV acyclovir was continued for 3 weeks. So at 3 weeks follow-up, the visual acuity was counting finger at 3 meters. Intraocular pressure was 6 millimeter of mercury, and there was resolution of vitritis, and the retinitis lesions were also healed with scarring. So further, we treated her with oral acyclovir 200 milligram 5 times per day. So at her 1 month follow-up, visual acuity improved to 6 by 36. Intraocular pressure was still low, 4 millimeter of mercury. The OCT showed multiple cystic spaces at fovea, and there was resolution of retinal detachment shown in base scan. At 2 months follow-up, fundus was stable, visual acuity was maintained to 6/60, her intraocular pressure was still low, 2 millimeters of mercury. OCT showed resolution of cystic spaces with thinning of retina, and she was then started on topical steroids. At her 3 months follow-up, intraocular pressure was still low, and we shifted her to topical difluprednate. At 4 months follow-up, visual acuity was 6/60, intraocular pressure was still low, and she had developed left eye posterior subcapsular cataract. Here she underwent left eye lens aspiration with vitrectomy, endolaser, and silicone oil implantation under steroid and antiviral cover. So at postoperative days 7, fundus was stable. There was pre-retinal heme and there was extensive gliosis in the periphery. 1.5 months post-surgery, her best-corrected visual acuity was improving to 6/60 with aphakic correction. Fundus was stable and IOP was still low, 2 millimeters of mercury. So at her last visit, base-corrected visual acuity was maintained to 6/36. Intraocular pressure was still low and she had started developing band-shaped keratopathy. Here we continued her on difluprednate eye drops and oral acyclovir 200 milligram twice a day as her maintenance dose. Thank you. Now, I would now like to pass the discussion over to Dr. Arshima.
Thank you, Rakshita. Am I audible?
Yes.
Okay. So I'll be taking you through pediatric ARN in 3 slides. First is the overview. Second is challenges in diagnosis. And third is management of these patients. Is my slide visible?
Yes, yes.
Yeah, okay. So after this case presentation, I think we all know the constituents of ARN. ARN is an ophthalmic emergency. It is mostly unilateral, but it can become bilateral in up to 15% of cases. We all know that VZV is the most commonly implicated agent in ARN, but when children are concerned in pediatric ARN, HSP is known to be the more commonly implicated agent. Now, HSP is unique because it is highly neurovirulent and it has got a tropism for the pediatric retina. It is important to know that the primary source of infection here is intrapartum transmission. This virus can then get lodged in the CNS, in the retina, and even in the visceral organs like the liver, and can get reactivated later on due to any sort of triggers. It is important to keep in mind that when you see a patient or a child with ARN, with certain typical associated features, you think of HSV infection. For example, if you see a child with ARN and associated exudative retinal detachment, you see ARN in a child with CNS disease, either signs of encephalitis, meningitis, or even a past history of the same. Or you see a child with ARN with associated old chorioretinal scars, you think of HSV infections. Now, the foremost challenge here is diagnosis, which would require GA or sedation to be able to completely examine these children, especially to look at the peripheral retina. An OT setup is essential. Please consider referral to higher centers if you do not have that facility available at your end. And I cannot definitely overemphasize a dilated examination, without which we would definitely miss the peripheral retinal necrosis. An ICU facility, if available for prenatal infants, should also be utilized. Now, after a clinical diagnosis has been made, it is important that now you confirm your diagnosis with molecular biology techniques like polymerase chain reaction. We do not advocate the use of serology to make a diagnosis. In cases where you're suspecting CNS disease or disseminated disease, neuroimaging is of utmost importance, and a timely pediatric referral is important for systemic evaluation and management of these children, which you may not be able to do alone. So it is important that you take the pediatrician's help at the correct time. Now, another issue here is follow-ups, and important thing is that we document this with optos photography, as was just being discussed by Dr. Ramod and Dr. Pathophysiology. It is important that we follow up these cases and document at each visit optos photography, because otherwise at every visit for examination, you will have to resort to either GA or sedation. So it is important that optos photography be utilized if available at your end. Keep differentials in mind when you are treating ARN, and look for these if you're not sure of your diagnosis or if your tests come out to be negative. Now, management of ARN is multi-pronged. The minute you have a clinical diagnosis, you start IV antivirals. Our preferred drug of choice is acyclovir, 10 mg per kg per day in 3 doses for 10 to 21 days till a clinical response has been established. If possible, if you have it the setup, intravitreal antivirals can be given as an adjunct because it helps in increasing the concentration of the antivirals in the vitreous. Either ganciclovir or foscarnet can be used till a response is seen. Now, HSV infections are also known to be highly reactive in the sense that they produce a lot of tissue reaction and retinal damage. So oral steroids should be started maybe 24 to 48 hours later at a dose of maybe 0.5 to 0.7 mg per kg per day and can be gradually stepped up to 1 mg per kg so that you can reduce the risk of optic neuropathy, you can reduce the vitritis, it helps in better visibility of the fundus. And once you're assured that now there is a good clinical response and the retinitis appears to be regressing, then these children can be shifted to oral antivirals like acyclovir or valacyclovir for maintenance. Now, here I would also like to leave you with the point that renal function monitoring is very important when all these children are on these antivirals because most of them are nephrotoxic. The role of VR intervention is very, very important when you are dealing with ARN. It is important that you take the timely help of your VR colleagues so that early breaks, early retinal detachment can be picked up and VR surgeries can be taken if there is RD or persistent hypotony like in our patient. So now I would just like you to leave with a few takeaway points. ARN is an ophthalmic emergency. A high index of suspicion is required for diagnosis. A thorough dilated clinical examination is mandatory. You can use PCR for etiological confirmation. Immediate and prompt treatment with antivirals. There is no need to wait for results while you institute therapy. Dreaded complications like optic neuropathy, retinal detachment, and hypotony can happen very quickly in these patients. The goal of treatment is also to prevent contralateral eye involvement and systemic spread of disease. A judicious use of steroids and close follow-ups is what I would like to leave you with. Thank you.
Thank you, ma'am. Thank you.
Thank you.
Thank you, ma'am. That was a wonderful discussion. Dr. Amod, sir, I think you have something to say about the case.
I think both Rakshita and Dr. Arshi, I mean, they presented it very nicely. And it's not very common to have acute retinal necrosis in children, and particularly the HSV, because we have known that in adults, it's the varicella zoster virus, which more often affects the acute retinal necrosis it causes. And HSV is mostly related to anterior uveitis, but here they presented an unusual case, which was also associated with encephalitis. Simultaneous occurrence of encephalitis in acute retinal necrosis is also not very common. And, the question has been asked often whether once a patient develops herpes simplex encephalitis, would he develop acute retinal necrosis? So the answer is that, well, it will be exceptional case who will do so. So they don't have to be followed up for development of acute retinal necrosis. And the likewise, the acute retinal necrosis going on to develop encephalitis is not a common finding. But one has to be careful about, as she rightly pointed out, do a wide angle photography to document appearance of new lesions or response to your treatment, which very rightly started with intravenous acyclovir and combined with, because it was a very fulminant case, if I may say.
Yes.
In this patient, they did very well to start intravitreal ganciclovir at 2000 micrograms per injection. So I think they managed it very well and saved the eye to the extent it was possible. The only thing we need to be careful in these patients is the development of retinal detachment, which is very frequently seen. And as she rightly said, it's an emergency. So one has to keep a watch out. So it's not necessary that your patient is healed and you send him home and come back as and when. No, you need to keep them under watch for development of retinal detachment, because the retina heals with sieve-like holes. So the retina, full thickness of the retina becomes atrophic, and they develop stretch holes in that and lead to retinal detachment. So I think one has to be very, very careful about development of retinal detachment, because repairing that could itself be a big challenge for the retinal surgeon, especially in small children like this. Yeah, thank you.
Thank you, sir. Thank you very much.
Thank you, sir. Thank you for your input. And thank you, Dr. Rakshita and Dr. Arshi Ahmed. That was a wonderful presentation. Next, we have a case from LVP Hyderabad. I invite Dr. Shruti Satpathy to present her case and Dr. Soumya Basu to guide the discussion. Dr. Shruti?
Thank you, ma'am. Are my slides visible and I'm audible to all?
Yes, yes.
Good evening, one and all. First of all, I would like to thank AIOS, LV Prasad Eye Institute, Dr. Basu and Dr. Partho for this opportunity. In today's session, I'll be discussing a case of granulomatous uveitis in a child. So we have a 12-year-old girl, resident of Rangareddy, Telangana, presented to our uveitis clinic on 15th January 2023 with the chief complaints of blurring of vision, which was associated with redness in both the eyes for the past 6 months. She didn't give any recent history of head injury or ocular trauma. She also visited a local ophthalmologist for her visual concern, where they diagnosed a severe uveitis in both the eyes and referred here for further evaluation and management. Her best corrected visual acuity in the right eye was 20/50 and 20/40 in the left eye. Intraocular pressure was 16 in both the eyes. And this was the picture on the day of presentation. The patient had 3+ cells in AC and iris nodules, which could be seen in undilated state. On a slit lamp examination and diffuse illumination, as we can see here, we can observe these small to medium sized grayish white granulomatous capes, which is arranged in triangular pattern, which is in the arch triangle inferiorly. And we have similar picture in the left eye as well. In the slit image, in the bottom image, we can appreciate this variable size fresh capes with fluffy border. So on fundus examination, we can see media appears hazy due to moderate vitritis in the right eye and mild vitritis in the left eye. Disc appears slightly hyperemic in right eye, and vessels arising from the disc appears to be normal. Rest of the fundus in both the eyes looks unremarkable. So since the patient had bilateral vitritis, we performed fluorescent angiography from right eye to left eye, where we see diffuse perivascular leakage, which is increasing in intensity and size as we proceed from arteriovenous transit to transit phase to late venous phase. And there are multiple small focal areas of staining, which is temporal to fovea, and nasal to the disc, which is increasing in intensity over time, but constant in size. These are not leakages as there are no neurosensory detachments present. However, we could have captured an OCT passing through this lesion. Disc here is showing hyperfluorescence in both eyes in the late phases. In recirculation phase, hyperfluorescence in the foveal and parafoveal region can be appreciated, which is suggestive of cystoid macular edema. So based on the clinical findings and imaging features, we reached to an anatomical diagnosis of both eyes panuveitis with retinal vasculitis and morphological diagnosis of both eyes granulomatous uveitis. And for etiological diagnosis, we still have to explore further. So at this point of time, we revisited the history when the patient gave history of painful mouth ulcers of size around 3 to 4 millimeter, which was occurring 3 to 4 episodes a year. 3 to 4 episodes a year, and it resolves spontaneously without leaving any scar. She also gives history of cough and shortness of breath for past 1 week. However, there were no history of any dermatological complaints. So we further wanted to investigate this patient for active tuberculosis and sarcoidosis in view of granulomatous pattern of uveitis, which was present bilaterally. So baseline investigations were within normal limits. And then we requested HRCT thorax, which showed multiple enlarged rounded discrete lymph nodes at these following locations. And the largest lymph node was measuring around 38 to 39 millimeter in subcarinal location, which was playing the carina. And there were no calcifications seen on the scan. So the largest lymph node was greater than 10 millimeters. So we went ahead with EBUS-guided biopsy, which showed necrotic epithelioid granuloma, and ZN stain was positive for acid-fast bacilli. So now we have these differentials for the case. First being ocular Behçet's. So ocular Behçet, it usually presents with bilateral panuveitis, and in fluorescein angiography, it shows diffuse pond pattern leakage. Also, patient had history of frequent painful mouth ulcers, which is again favoring towards Behçet's. However, points against this differentials are presence of granulomatous capes, iris nodules, and redness, which is not seen in Behçet. Also, the age of onset is 20 to 30 in Behçet. So, my second differential is early onset sarcoid and Blau syndrome. Both have similar presentations, and early onset sarcoid is sporadic. However, Blau's is familiar due to mutation in NOD2 gene. And talking about this differential bilateral granulomatous anterior uveitis is favoring this diagnosis. But the age of onset is typically less than 5 years. And also other systemic features like dermatitis and bulky swelling of joints were not present in my patient. So the third differential, we have ocular tuberculosis, and points favoring this type differential are presence of granulomatous uveitis and lymph node biopsy showing ZN positivity for acid-fast bacilli. However, patient did not have any history of TB contact. And the last differential is tubulointerstitial nephritis with uveitis. Again, age of onset, female preponderance, and bilateral anterior uveitis pointing towards TNU. And granulomatous presentation is against this differential. And also, our patient urine analysis were within normal limit. So summarizing my case, we have a 12-year-old female from Telangana presented to us with chief complaints of blurring of vision and redness in both the eyes. On slit lamp examination, we could see granulomatous capes, 3+ cells, and iris nodules. On fundoscopy, we could see moderate vitritis, and on fluorescein angiography, it showed diffuse fern pattern leakages along with cystoid macular edema. So then we did HRCT and it showed significant lymph node in the mediastinum. And we went ahead with EBUS biopsy, which showed ZN stain positive for acid-fast bacilli. So with this background history, imaging findings, and relevant investigation, a provisional diagnosis of granulomatous panuveitis with TB tubercular etiology was made. And the patient was started on oral steroids, prednisolone, 40 milligram once daily for 3 weeks, along with supplementation. And also, we started her on weight-adjusted 4-drug anti-tubercular therapy. So after 3 weeks of follow-up, vision remained same. However, we can see the edema, macular edema has cleared up, which is evident in the thickness map. Here we can see the macular thickness is normalizing in the right eye. However, there is still some edema persisting in the left eye. So considering good response to treatment and infectious nature of the disease, oral steroids were tapered fastly and anti-tubercular therapy was continued. So after 6 months, vision improved to 20/20 in both the eyes. And this is today's fluorescein angiography, follow-up after 1.5 years. We can see the diffuse pattern leakages are completely resolved. And the patient is enjoying vision of 20/20. Also in the thickness map, we can note that macular thickness has completely normalized. Thank you for your patient listening.
Thanks, Shruti. Can you go back to the differential slide? So good evening, everyone. I'll just discuss this case in brief. So we had a 12-year-old female who had a relatively recent onset intraocular inflammation. The points to note in this inflammation are first, it was granulomatous anterior-uveitis with iris nodules and mutton fat keratic precipitates. There was moderate vitritis in one eye and mild in the other eye. And there was intense retinal inflammation, which was reflected in the fern pattern leakage that we saw. There were also 2 points of intense staining on the retina, but we could not clarify what might have been those lesions. Now, amongst all these points that I just mentioned, the one that stood out for me was the granulomatous inflammation, and which is why, despite the fern pattern leakage, I was tilted towards the differentials for bilateral recent onset granulomatous inflammation. Now, even though this child was in the second decade and did not have any systemic signs of early onset sarcoid, such as the arthritis or the dermatitis, sarcoidosis was the first differential in my mind, especially because her Montu test was also negative. So we went ahead with the chest imaging, and we found those large lymph nodes which were non-calcified in nature. And since the lymph nodes were large enough, we further went ahead with the EBUS guided biopsy. And the biopsy revealed the truth, which was acid-fast bacilli. That, you didn't need anything more. So on that basis, we went ahead with the treatment for tuberculosis. And since we had an infectious etiology that was responding very well to the inflammation as seen on the macular thickness map, we could taper the steroids quickly, and the patient got back good vision very, very quickly. So this is an example where, despite having hints of an alternative non-infectious diagnosis, which could have been Behçet, which could have been early onset sarcoid, we ended up with an infectious diagnosis and got very good outcome. And we also presented the current data, the current picture, which is more than 1.5 years since we last saw her, and the patient is doing very well. Thank you, Parth.
Thanks. We are lucky that we have Dr. Basu and Amod Gupta sir both here. So I just want to ask you people that, is there any clinical phenotype-wise any difference between adult and children when it comes to ocular tuberculosis?
I doubt if there is any difference in the presentation, phenotypic presentation. But I have a couple of questions for Dr. Basu. And we keep debating, sometimes once in a while. So first question is, where would you put it in the anatomical classification? Would you call it a pan-uveitis? Would you call it a anterior and intermediate uveitis, or it's just the anterior uveitis?
I must confess, as I should have corrected it in the on the slides, but I would rather call it intermediate uveitis with granulomatous anterior uveitis.
Right.
The capillary leakage that we are seeing on the fluorescein angiogram is just a surrogate measure for the intense retinal inflammation. That cannot be called as retinal vasculitis. So, my apologies.
That is the point I was going to ask you,
Yeah.
Because currently, I think they're trying to reclassify retinal vasculitis. And very often, the breakdown of the blood-retinal barrier is being confused with calling it vasculitis. So unless I see perivascular infiltrates, or in the heel stage pipe stem sheathing, I wouldn't call it vasculitis. I would call it a breakdown, which could happen because of the, I'm sure there are a lot of cytokine influx, IL-6 or whatever, TNF in this patient, which leads to breakdown of the endothelial barrier and cause this kind of edema. And this we are, I think, being reported more often now in all types of uveitis in children, that they have, if you do a wide angle, ultra wide angle fluorescein angiography, you will see this kind of leakage is very, very common and not as rare as it was believed to be. So as you rightly said, you would call it only as a vascular breakdown rather than uveitis. But good thing that you have done. I think lesson to be drawn from this particular patient is that you ordered a HRCT, okay, and found lymph nodes large enough. I mean, almost 4 centimeter lymph node is a big deal even in TB lymphadenitis. And you could find AFB positive. So I think what we have reported in our own series, 12 such patients where children were asymptomatic, they didn't have disease, but probably, as is Dr. Basu calls, a subclinical tuberculosis even in this particular patient, and you demonstrate that the AFB is present. So I think the lesson which goes from this patient is that you should not hesitate in an endemic country like ours to order when you want to treat them on corticosteroids. Order a CT scan. I would my chest physician, when they were planning e-bus for our patients, they preferred a contrast enhanced. And they say that can pick up the active inflamed lymph node much better than HRCT. No doubt HRCT gives you high resolution, but that doesn't tell you which lymph node should be approached. So if you do a contrast enhanced, so those which are enhancing lymph node, then you can have a pick for doing an EBS procedure. But I would recommend again what you have taught in this case, that go out and not be in a rush, establish a diagnosis by any which means, okay, and treat, and you will have spectacular outcome like in this particular patient. It's a fantastic case of TB.
Thank you, sir. Can I add a couple of points, Partho?
Yes,
this is not about TB, this is about Behçet. The moment we see that fern pattern, and this was a very intense fern pattern leakage, not the regular that we see in intermediate uveitis. The temptation would be to test for HLA-B51. I think that is something we should be aware of, that B51 has very low sensitivity for Behçet's disease. Up to 12% of the normal population is B51 positive, and up to 30% of Behçet's patients are B51 negative. So that has that never even crossed our mind that we should be testing for B51. Otherwise, we would have landed up in trouble. The other important point on Behçet is granulomatous inflammation. We saw iris nodules, we saw mutton fat KPs. Now, granulomatous inflammation will never be seen in Behçet's disease. It's a neutrophil-driven disease, and that will never get granulomatous inflammation. So that's where we shifted our track from Behçet towards the granulomatous diseases, which were TB and sarcoid. Thanks, Parth.
Okay, so I have a couple of questions from the audience because my fellow Dr. Anjana is sending me the question. So I have one question, is that what is the optimum age for advising a Monto test in children?
You, sir, would you?
I think if you are hinting at the BCG vaccinated children, I think the effect goes away by the time they are 10 years old. So anything positive after that should be taken a little seriously. But I would still look for evidence, systemic evidence of TB lymphadenitis if there is no pulmonary TB, and mediastinal TB is pretty common. But sometimes these overlooked, the cervical lymphadenitis gets overlooked, or abdominal TB gets overlooked. So one should look for a thorough systemic examination, I would say, more than I depend more on that and do a very, very targeted lab to confirm or reject a proposition or a hypothesis, and not do just like that. Let's do Montos for all. Everybody will be positive in India for that.
Thank you, sir. So there is another question from Dr. Harsh Jain from NIO Pune. Should we start TB medication along with oral steroid or prior to it? I think it's a comment, but you have to reply because...
Yeah, Dr. Basu is an expert on that.
Yeah,
he has treated them without corticosteroids and they got well. And I would have started
in children also, Dr. Basu?
No, in this patient, definitely a lot of steroids. I mean, this was retinal inflammation. And remember that the main cause of vision loss is the retinal inflammation. We tend to overlook that in the absence of a retinitis lesion. But, I just add one thing here, that currently in our, institute, I think the uveitis department does more fluorescein angiograms than the retina department. And I've heard the same story from Bascom Palmer Eye Institute as well, okay, maybe with you as well. So this is the reason why we get the fluorescein angiogram done. And it's to highlight the amount of retinal inflammation, because that guides the intensity of our treatment. And this is one case where you saw it, and there's no way you could escape steroids in this patient.
I think you made a very, very valid point about the intensity of inflammation, the requirement for corticosteroids. And just a small point about OCT angiography, those who have this, they are, doing it as a substitute for fluorescein angiography. It's not a substitute for fluorescein when you're trying to look for blood-retinal barrier. And I think the ophthalmologist would rather avoid it. The uveitis experts would rather avoid ordering OCTA before doing a fluorescein angiography.
Thank you, sir. I think it's one of the important takeaway part of this session, that OCTA is not a substitute for the fundus fluorescein angiography. So there is another question from Dr. Pallavi Goyal. How useful is chest X-ray for tuberculosis, or is it obsolete now?
I think, there are multiple studies from your institute, from PGI, that have shown that the CT scan has much higher sensitivity than the chest X-ray. So given a chance, you would always want to do CT scan, as sir said, preferably a CCT scan when your target is the lymph node. So if your target is the lung tissue, probably an HRCT is a better option. This is what the radiologists tell us. But if your target is the lymph node, which in fact is the case for most of our patients, be it TB or be it sarcoid, because they do not have any obvious lung disease, the ones that come to us, most of them. So, from that perspective, CCT thorax is what we should be going for.
I think last question. 100%. I don't think there is any role for X-ray chest if you're seriously investigating a patient of granulomatous uveitis, and you must go in for, and the cost is not a factor. The radiation exposure with the modern CT scanners is probably not as much as was hyped some years ago with the first, second generation CT scanners. So you should not be worrying about that part.
Thank you. The last question is that when to go for ocular biopsy in such cases of ocular tuberculosis or presumed ocular tuberculosis, especially in children.
Can I take? Sorry.
Yeah. You do that. You do that. You do it much better.
Yeah. No, I we have had wonderful publications on PCR, and I think the biopsy is from the context of PCR is what the question is about. And we have so many from PGI and some from us as well, and from SN. But, I am not a very firm believer on the role of PCR in tubercular uveitis, and especially in a scenario where you do not have enough of inflammatory cells. Remember that MTB is an intracellular bacterium. So if you do not have enough inflammatory cells in your samples, and the typical scenario is in a patient with serpiginous-like choroiditis, we do a AC tap where there are no cells in the aqueous humor. It's never going to yield any kind of result. So that is one reason why I would avoid PCR. So a lot of chances of having false negative results, but also, as our data shows, that there is a good chance of having false positive results, because being in a TB endemic country, you may have the dead bacilli moving around in the monocytes. So for these reasons, we do not usually practice PCR for tuberculosis. We do much more PCR for viruses, but not so much for tuberculosis.
Thank you. So thank you. So we'll move on to the next case. So next I invite Dr. Aishwari and her mentor, Dr. Alok Sen, to present a case, and they will be presenting a case and discuss about a child with ocular toxoplasmosis. Over to you. Are you there?
I'll just share my slides.
Okay.
Hello, sir.
Yes, we
Yes.
can hear you. And
Yes, sir. Sir, am I audible?
yes,
Hello. Yes,
we
sir. Good evening to one and all. I, Dr. Aishwari Revankar, fellow in the Department of Retina and UVEITIS Services, would be presenting a case today under the guidance of my mentor, Dr. Alok Sen, Head of Department of Retina and UVEITIS Services at Sadguru Netra Chikitsalaya, Chitrapur. The case for today's discussion is that of a 11-year-old male, resident of Shadol, Madhya Pradesh, who presented to us with diminished vision in right eye since 10 days. Patient had a history of fever 2 months back, which lasted for about 2 to 3 days. On examination, the vision in the right eye was 4/60 with quiet anterior chamber and presence of cells in the anterior vitreous space. On fundus examination, there was presence of punctate white lesions at the posterior pole involving the fovea. There was also presence of deposits along the veins with some amount of venular segmentation evident. On left eye examination, the vision was 6/9 parts with anterior segment and posterior segment findings within normal limit. So based on the history and clinical examination, we came to an anatomical diagnosis of right eye punctate retinitis with retinal vasculitis. And we went ahead with ancillary investigations for this patient, including optical coherence tomography, wherein a radial scan passing through the fovea of right eye showed presence of partial separation of posterior hyaloid. There was presence of hyperreflective clumps suggestive of preretinal exudation and presence of hyperreflective dots in the posterior hyaloid face. As we can see in the image, there was presence of hyperreflectivity in the inner retinal layers suggestive of inner punctate retinitis, along with a full thickness necrotizing retinitis involving the fovea, with an increased subfoveal choroidal thickness of 566 micron. We went ahead with a fundus fluorescein angiography for this patient, wherein on consecutive frames, we can see there is increased punctate hyperfluorescence in the perifoveal area, along with a hot disk. On indocyanine green angiography, we could see there was a presence of hypofluorescent dark dots on the involving the posterior pole with the presence of satellite dark dots just superior to the fovea. So based on all this, we kept certain differentials in mind like ocular toxoplasmosis, viral retinitis, and syphilis. And we went ahead with labs for this patient, wherein the VDRL and TPHA titers were non-reactive. Although the IgM titers for toxoplasma were within normal limit, the IgG titers were elevated, and the rest of the investigations were within normal limit. So we made a probable diagnosis of right eye toxoplasma retinochoroiditis with punctate inner retinal lesions. And we started the patient on a combination of tablet sulfamethoxazole plus trimethoprim twice a day. And after 2 days, we started the patient on weight-adjusted oral prednisolone of 40 milligram once a day. So at presentation, the vision was 4/60 with the corresponding involvement of the fovea and inner retinal layers on OCT. Just after 1 week of treatment, the vision improved to 6/60 with significant healing noted on the corresponding OCT image as well. At 1 month, the vision improved to 6/18 with the persistence of some amount of hyperreflectivity at the temporal edge of fovea, as we can see in the OCT image. At 2 months, the vision improved significantly to 6 parts with significant healing on the OCT findings as well, with persistence of disruption of the ellipsoid zone. And at 3 months, the vision was stable at 6 parts with healing noted on OCT findings with persistence of disruption of ellipsoid zone. Thank you.
So I'll take up. Thank you, Partho sir, for the opportunity. So this this is about pediatric uveitis. So we know that ocular toxoplasmosis can happen in children, and it can be congenital when it is transmitted transplacentally, where usually the presentation is a chorioretinal scar in the posterior pole. However, they can also present due to reactivation or acquired infection postnatally. And the typical presentation is when you have this chorioretinal scar, and adjacent to it, you have a focal retinitis lesion with variable vitritis and some amount of adjacent vasculitis. But the problem is when you have atypical presentations like this, where we had punctate retinal lesions, and we were not knowing whether whether we were dealing with toxoplasmosis or something else. And here comes the role of multimodal imaging, when you see that the central part of the lesion was a very typical presentation of toxoplasmosis, where you have a full thickness retinitis. There is elevation of pigment epithelium and a focal choroidal lesions just below that retinitis. And along with that, you have these punctate inner hyperreflectivity, which were restricted to the outer plexiform layer. And you can see it throughout, adjacent to the central typical lesion. And on FFA, you see these focal leakages, which corresponds to the areas of hyperreflectivity on the OCT, while ICGA, which showed an area of dark dot corresponding to the central typical lesion, and a satellite dark dot, which is typically has been reported in cases with ocular toxoplasmosis. So with this, we made a diagnosis just based on clinical and the OCT pictures. We made a probable diagnosis of ocular toxoplasmosis with inner punctate lesions, and we treated the patient. In these cases, although in most of the cases of ocular toxoplasmosis, you really don't need a serology for a diagnosis, they are only supportive. And even in this case, we started the treatment awaiting the serological report. The serology generally helps you in as a supportive to your diagnosis. And if the serology is negative, then you may think of some other alternative pathology, especially in atypical cases. So to summarize, punctate inner retinal toxoplasmosis, this is a beautiful paper from LVPI group, is a typical form of ocular toxoplasmosis. And in these situations, the multimodal imaging can be very helpful, particularly the OCT can be very helpful in making the diagnosis. And typically these inner retinal lesions, they heal without much of significant retinal alteration. And I thank you all, and especially Professor Amod, for always being supportive to us and helping us with our uveitis work. Thank you.
Nice.
Thank you, Dr. Aishwari and Dr. Sen, for that insightful discussion. We're wrapping up with all the case discussions. And before we conclude this enriching session, it is an honor to invite our stalwart, Padma Shri, Professor Dr. Amod Gupta, for the final talk of the day. He will be sharing with us his wisdom on managing uveitis in children.
Just confirm if I am visible, my slides are visible.
Yes, sir. Yes, sir.
Yeah. So I'll be sharing some of your thoughts on how to manage pediatric uveitis. And first of all, I'd like to point out it depends on your practice. And here I've chosen two referral centers in North India versus two in the South, and two from the Europe and UK, where basically the last UK and the Spanish registry is non-infectious uveitis. And the number of patients they see is per participating practice is very few compared to, say, RPC or Sankranithralya. So I think it depends on what kind of practice you are in before you expect these children to present to you. And like we've seen here in the UK and Spain registry, the majority of the cases, and even in India too, you would expect them to be anterior uveitis rather than posterior or pan uveitis, you can see. And probably it's a reflection of not including posterior and pan uveitis in their registry, but that itself shows that probably it's much less in their population. The intermediate uveitis next to anterior uveitis is the intermediate uveitis that you're likely to see in your practice, and we've had good discussion on this topic. And as you can see, the RPC and the Sankarnetrale, they have almost a quarter of their patients presenting with the intermediate uveitis in their practice. And this is a reflection of probably in our setting, it's a multi-department institute. So we see a lot of posterior and pan uveitis compared to intermediate uveitis. And so does Dr. Kalpana, probably who has created name for herself, diagnosing sarcoid and a variety of these granulomatous disorders. So probably that's the reason she sees a lot of pan uveitis and posterior uveitis. So essentially, it is the type of practice that you are in that will determine the anatomical location of the uveitis. Having said that, what then are the common 5 top causes of infectious uveitis? Because time doesn't allow me to go into all the kinds of infectious uveitis, but here you would see it's in our center. I think we have seen over a period of 15 years, 55 cases of tuberculosis in the pediatric age group, compared to just 5 cases. And this group actually wrote a letter to the editor, to the journal. How come they have 55 and we have only 5? The reason being that we have been diagnosing ocular tuberculosis for the last 45 years. And perhaps in the center in Delhi, they are diagnosing only last for a few years. The others are Toxocara in children, and we have seen a nice case of Toxoplasma. And surprisingly, the Delhi center doesn't have any case of Toxocara, and Sankarnetralia does have. And then you have viral, and we have seen that beautiful presentation from Sankarnetralia, who seem to have the maximum experience till they reported on viral uveitis. Now, what are the top 5 causes of non-infectious uveitis? And here I'd like to point out that a large majority of our patients have rheumatological disorder in children. And that again represents, because ours is a very strong pediatric rheumatology group and a very strong rheumatology department. Actually, rheumatology, by and large, pediatric rheumatology started from PGI. And that is why we are seeing a lot of these patients with so-called juvenile idiopathic arthritis. And the others are, of course, Fuchs and VKH disease. So people believe that VKH is a middle age or adult or young people. No, it's seen in maybe not as frequently as adults, but it's seen these cases, and they are actually very challenged because they appear late typically, and it's a challenge to manage these patients well. The third is the funny gait that improves in the morning. Is the typical presentation to the rheumatologist of patient with juvenile idiopathic arthritis, and has been discussed as bilateral insidious ad nauseum. It has been discussed how it affects the young girls, very young. Important thing is, like it was pointed out in discussion, that some patient may present with 3 to 5% may present with uveitis first and arthritis later, but more than 90% of the patients would first go to a rheumatologist with their arthritic problems, and only then they will develop after years, and mostly within 4 years. By and large, all of them will develop uveitis within 8 years of the diagnosis of arthritis. Also important to know that the nomenclature has been changed from posioarticular to oligoarticular, which means 4 or less joints which are effective, and this is a asymmetric arthritis, unlike the rheumatoid factor positive arthritis, which is not only polyarticular, but also tends to be symmetric. Now, another very important point to remember is that inflammation of joints are independent of each other. So when the joint is active, you may not have any eye inflammation. When the eye is actively inflamed, it may not have the joint simultaneously inflamed. Now, this again is a very important table, which introduces the concept of persistent and extended oligoarthritis in JIA. And persistent means that the involvement of 4 or less joints occurs over a span of maximum 6 months and doesn't exceed the involvement of joints beyond 4 up to 6 months. It's called persistent. And here ANA is positive in almost like 60%. But extended is that, well, more than 4 joints can get involved after completion of 6 months of the initial onset. So that is called an extended. And these are the ones who are likely to get uveitis. So those who have had through history of the type of arthritis that they have had or the rheumatologists have noted is very important. And of course, then there polyarthritis, which is rheumatoid factor negative, and the rheumatoid factor, sorry for the here it should be RF negative and RF positive polyarthritis, so which is much less common. Now, this is essentially for pediatric rheumatologists, but you also need to probably educate your rheumatologist, those who have big practice of JIA uveitis, when they should start sending. So if the high risk is patients who have oligoarthritis and their age of onset less than 6 years and they are ANA positive, they are a very high risk. As I said, almost like 30% will develop uveitis. So you need to screen them on slit lamp every 3 months. But if the ANA is negative in a child who's less than 6 years old, maybe 6 months would do, because these patients will have a medium risk of developing about almost like 10%. And a low risk is a systemic onset of uveitis, systemic features, but they also need an annual checkup. Now, remember that the joint deformities, when you see, are more common. You don't see them in JIA oligoarticular, but in polyarticular JIA, which is older age at onset and longer duration, and they present typically with deformities in the fingers. I think Dr. Padma very clearly gave the algorithm for treatment of JIA uveitis. I'll just sum it up again. And aim is to have less than 1+ cells in the anterior chamber. And start with topical steroid when they're coming early. And mind you, when they are being referred for routine examination and you pick them up on slit lamp, you start with topical corticosteroids and persist for about 3 months. And if there's no response up to 3 months, then methotrexate weekly, intramuscular or subcutaneous, should be given, because this has a better absorption than the given orally, which has poor absorption and irregular dosage is the case. If there is no response to the immunosuppressive therapy, then you need to, as was very adequately mentioned, to adalimumab. Etanercept is best avoided. It itself causes inflammation, is best avoided in this patient. Now, she had also mentioned that once it is controlled with 1 to 2 drops per day, then taper systemic therapy only after it has remained quiescent for 2 years. You do not taper off systemic methotrexate or adalimumab before 2 years, and only if you find that only 1 to 2 drops are required. And then, as she also rightly mentioned, that taper topical steroid first before stopping the systemic, which needs also to be tapered systemic therapy. Now, the point I think which was not mentioned, and I would like to emphasize, and I'll give you my reason for it, that childhood onset uveitis must be co-managed with a pediatric rheumatologist, preferably, and if not, then a rheumatologist at least. Because otherwise you are likely to miss these monogenic autoinflammatory disorders, which are associated. And there are a number of uveitic associations with a number of, I think more than 40 autoinflammatory diseases are presently known. They are rare, but once they are detected, discovered, they have probably a different line of management than what we do with the non or immune mediated uveitis. Now, it's very interesting that the patients who were diagnosed and treated as JIO-associated uveitis, nearly 1/5 had actually a BLOS syndrome because of NOD2 mutations. And typically, they are associated with skin lesions, dry skin, rash, ulcers, papules, erythema nodosum, and erythema. And they would require a change in treatment if it is diagnosed as BLOS. Now, I like to share one of my own patients, which we had seen at the age of 13 years. This young girl had presented with secondary glaucoma, and a large iridectomy had been done to relieve the iris bombae, and had band-shaped keratopathy. And you can see the ring-like synecdoche in both the eyes at the age of 13 years, and she had a granulomatous uveitis. She had been treated for the last 10 years before she presented to us irregularly for arthritis. So she had been not receiving a regular treatment. We put this patient on injectable methotrexate, and for the next 7 years, it remains controlled. And she didn't require any other change till at the age of 21 years, she presented with systemic granulomas in the liver and kidney, and she had these deformities in the interphalangeal joints. So this was labeled as multi-organ involvement in a BLOS syndrome, and was duly reported by our pediatric rheumatologist colleagues. So these patients need to be, as I said, 1/5 GIS uveitis may have underlying BLOS syndrome. Now, what are the factors that favor BLOS syndrome? One is that they are ANN negative minded. So you have to be particularly watchful for ANN negative patients. Age of onset in these patients is 3 years or younger, unlike 3 to 5 for the JIA. And they have a positive family history of uveitis, arthritis, and cutaneous lesions. And they have joint deformities. And of course, they have cutaneous lesions beside. So any child with cutaneous lesions, the skin lesions, of a variety of skin lesions, family history, and often on pain, self-resolving pain, abdomen, or fever, or skin lesion that heal on their own, or arthritic swelling, boggy swelling, somebody mentioned. So these should be seriously look for BLOS syndrome, and so that they can be treated. The fourth, which is often missed world over, is the young females predominantly have bilateral sudden onset of acute uveitis, which can be painful, and also the raised intraocular pressure. Typically, we have considered raised intraocular pressure for viral uveitis cases. Here we have these patients who have bilateral. Viral uveitis with raised pressure is typically unilateral. And here I'm talking of young girls having bilateral acute onset uveitis with raised intraocular pressure. And they may also show on fundus fluorescein angiography, as I was mentioning a little while ago, in the peripheral vascular leak, optic disc, or macula. These are the patient of tubulointerstitial nephritis and uveitis. TINU is underdiagnosed. In young girls of uveitis, 1/3 of them have TINU syndrome, which remains undiagnosed because we don't suspect. So one needs to, if you have a patient of bilateral acute uveitis, specifically in women with raised pressure, you ask for history of any of the drugs intake, like antibiotics or NSAIDs or diuretics or any some such thing. They have two systemic features. One is an acute tubulointerstitial nephritis, which have pain in the flanks and may have hematuria and oliguria, renal this thing. The other is a chronic tubulointerstitial nephritis presentation, which has fatigue, loss of appetite, weight loss, and nausea. Now, if you need to ask these specific symptoms, do you have these? Because they may require lab investigation, beta-2 microglobulinemia, or even a renal biopsy may be required. And they would, because if it happens in older age, they tend to develop a chronic kidney disease. chronic kidney disease means gone into a renal failure. So early diagnosis is required for these patients. I think subject of Masquerade was very nicely discussed by Dr. Mohit Dogra. And I would just like to add a hypopion in a child, because there's some discussion of poking a needle into the eye. I think there is a little change in the perception now. And some of these patients who present with hypopion, this is a immune privileged site, and these lymphoma cells, they find a niche in the ocular tissues and may present to the ophthalmologist as hypopion. So a child, 4 years, 5 years presenting with hypopion, it may be much better to put a needle there, because systemically they may not have, and they may be, like in this particular patient was in remission actually, and the pediatrician said that, well, our patient is absolutely fine. But the moment we demonstrated that this patient harbored, lymphoblastic cell in the antechamber, then they had to revise their strategies about that. And of course, the large cells, as he has shown, the pearly white deposits in the antechamber, are more like infiltrative retinoblastoma. Now, we've discussed the role of corticosteroids, topical, oral, and biological, both synthetic as well as biological DMARDs so much. Remember that Ozurdex is not, approved by FDA for use in children, and because there are not much reports available. And here was, I think, 11 years old girl, bilateral intermediate uveitis, didn't tolerate systemic steroid, which were given for about 2 weeks. And we, in our own wisdom, thought of giving an Ozurdex injection. And from a 6-12 vision to counting finger, she dropped and presented with loss of vision, choroidal detachment, and she had a peripheral TRD, which became more aggressive looking. And I lost my sleep for the next 2 weeks till she recovered. Remember the Ozurdex 22 gauge applicator, in children with the low scleral rigidity, there is no spontaneous closure of the opening in the sclera, and that's why they have a leakage and hypotony and choroidals, and it can be a very nasty situation when the patient loses vision. Fortunately, she recovered, but taught me a lesson not to use Ozurdex as a treatment for these children of intermediate uveitis. I just like to highlight, which unfortunately was not discussed so far, was the UBM. The role of UBM is critical in evaluating complicated cataracts, which these children often present. And it will show you retroiridial. It will show you the peripheral synechiae here. Of course, you can see clinically also, but it will show you on UBM very nicely. It will show the cyclitic membranes, and this you will see the ciliary process is getting blunted. So this UBM will decide what kind of surgical procedure you are going to do. Like in this particular patient, this patient had been quiet for more than 3 months has received intravitreal dexamethasone, 3 implants, and this child preoperatively and was quiet, had a lot of synechiae. His media underwent a phacoemulsification along with intravitreal dexa was given during cataract surgery, and the patient recovered 6/9 vision at about 15 months of follow-up. Everything was fine. And a lot of people recommend putting an implant because the quality of vision is much better than if you don't put an implant. But remember, these patients tend to have post-operatively capsular adhesions and extensive fibrosis, which could be kind of perilenticular and extensive fibrosis behind and in front of the intraocular implant. And I'll show you a case of that. The other is a hypotony. If it is acute inflammation, and like a case was presented, and if it is inflammation induced, then probably it will resolve with the control of inflammation. But we have to be mindful of a pressure which is less than 6 millimeter, which could be because of cyclitic membranes, because ciliary atrophy, because of ciliary detachment, because of the tractional membranes. So we have to be, so no surgery is planned without, in hypotony and cataract without doing UVM. Now, here is a patient who had, you can see the ciliary atrophy here, and this patient was subjected to PPL and vitrectomy in this eye and recovered reasonably good vision. And we had to actually resort to giving posterior subtenon canologue in at frequent intervals to maintain the pressure of this particular patient, but at least the patient could go back to school. And surgical goals is to remove all the cyclitic membranes, all the retroirodal membranes, and the tractional elements. In cases where there is a ciliary body atrophy, which is seen on UVM, hypotony will not recover following partial nasectomy and vitrectomy. You need to, even if you remove all the cyclitic membranes and the tractional membranes, it will not improve, and you have to replace the vitreous with silicone oil. And maybe my choice had been 5,000 centistokes, would require replacement, which is not a big deal, because for the restoration of vision, which may be at best ambulatory, some of the patient is very, very desirable. And as I said, this is another example. The patient, even with 6 millimeter pressure, is seeing 20/30, and this young girl went on to complete her graduation in the university, and she was, as you can see, a hypotenuse glow. So the other, we need to see the axial length on ultrasound examination in these patients, and many of them you will find very short eyes, hypotenuse globes, and they also would require. So if there is a hypotony, a short axial length, and if you see cyclitic membrane, retroirodal membranes, ciliary atrophy, the intraocular lens implant is absolutely contraindicated. You would cause a disaster, like I would show, like this particular patient who was an 8-year-old female who underwent a phacoaspiration and Ozurdex injection in 2011. Within 15 months, she had developed extensive fibrosis around the implant, and she had actually, if I remember correctly, she had new vessels on the iris. And I sent back to the phacosurgeon that this is what has happened. He says, well, I'm going to remove this fibrous membranes. So a lot of surgical manipulation was done to remove all those membranes. The implant was removed. You can see the decompensation of the cornea, and 3 years later she required a glaucoma drainage device in both the eyes, and you can see the here the drainage device in this eye is not very clearly seen in this. These patients require a very long-term meticulous follow-up once you have done, as I've shown you, that there's extensive fibrosis, capsular fibrosis. I have seen implants which have been pushed out of the capsular bag and they were lying in the anterior chamber. So aggressive is the fibrosis. So in these patients, please don't dismiss them soon from your clinic. Once you plan, and I believe a lot of general ophthalmologists and cataract surgeons would be watching it. So for their sake, I'm telling that these patients would require a lifelong follow-up till you or the child goes. Thank you very much for the opportunity. So these were my 10 pearls. If you wish to add any more, thank you, Partho, for the opportunity.
Thank you so much, sir, for a great talk as usual. And we are always indebted to you for these valuable pearls and tips you share with us. So I think we have reached the end of this webinar. It's already 9. So thanks once again to Dr. Santosh Honavar, the General Secretary of AIOS, for giving us to highlight to create the awareness about this pediatric uveitis. A big thank you to all the panelists and the presenters for your wonderful presentation and discussions. So we'll conclude, sir. Thank you.
Thank you, Partho, for a very nice illustrative webinar. And I think a lot of learning points in all the cases that you did. And I just made a little effort to sum up some of those things which were already discussed and debated, and some other points which were less debated. Thank you very much. Thank you all for making it a very
Good night, everyone.
Good night, everyone.
Thank you.
Good night, sir.
Thank you so much.